Thank you, sir. So I welcome the panelists again. So our case, 53-year-old female, presented with jaundice for 3 months, fresh blood in the stools on and off. She also had history of treatment for arthritis with tofacitinib and methotrexate for 1 year. She also had jaundice, pedal edema, and ascites. On evaluation, her bilirubin was 20, INR of 1.24, creatinine 0.64, sodium 131, platelets 19,400. She underwent plex twice. She underwent USG-guided liver biopsy, which showed drug-induced cholestasis with hepatitis. She underwent the routine CT scan, abdomen, which showed thickening in the sigmoid colon. Dr. Naeem, would you evaluate this further? She had a thickening in the sigmoid colon on routine evaluation. Would you evaluate this further? For you. You. Yeah. So there is a thickening in the sigmoid colon. Should we evaluate this further?
Should we?
Evaluate this further.
Yes, this has to be evaluated with CEA and colonoscopy, full colonoscopy, to see and take a biopsy. We cannot ignore such kind of a thickening.
Yes, sir. We did CEA, and CEA is around 9.04. Also, we did colonoscopy. Colonoscopy showed a growth at 20 centimeter, and biopsy showed moderately differentiated adenocarcinoma. Should we do anything else further now?
We need to stage the disease, so patient would need a PET scan and stage the disease.
Yes, sir. We did PET scan. PET scan showed no metastasis. So we now have a patient with subacute liver failure with coexisting colonic malignancy. Guidelines says that patients with active liver cancer should be excluded from liver transplantation except those with selected indolent or very low grade cancers. So Dr. Sainath, what is the 5-year survival for a patient with stage 2 or stage 3 colonic cancer?
So for a stage 2 and for stage 2 it is definitely more than 85%. Yes. And for stage 3 it's somewhere, even the recent IDEA meta-analysis where the trials were done to see whether 3 months adjuvant was 6 month adjuvant. The data showed it was more than 80% in most of the garden variety. In younger patients, it's still around 76 to 78%.
Okay. Dr. Naveen, considering the 5-year survival of more than 60%, what are the treatment options at this stage? Should we palliate or offer transplant? So very good 5-year cancer-specific survival, but she's suffering from subacute liver failure.
So I didn't get why subacute liver failure in this case, sorry.
She has jaundice and she also had encephalopathy.
INR is normal, right?
INR is normal.
There's no ascites.
She underwent plex twice.
Okay, so reason for the jaundice, reason for the...
Drug-induced. So the team has decided to go for transplant in this case, and we found that there is a coexisting malignancy.
Okay, so I think first we need to understand a bit more about the liver disease, what is going on, where we stand in terms of the liver disease. Based on that, if there is obviously malignancy, based on the liver disease itself will dictate on whether we should go for resection or for the transplant or the palliation. But I think looking at this, probably palliation is what I would think about this at this point of time.
Okay. Dr. Naeem, would you like to differ?
Yeah, with a decompensated disease, I don't think chemotherapy or any form of surgery would help. So I would consider stage the disease and think of transplant along with simultaneous treatment of the tumor or treatment of the tumor just after transplant.
Yes, sir. We also decided to go ahead with transplant. So, Dr. Shantan, what will be the sequence of treatment? The patient is with subacute liver failure, would not tolerate chemotherapy, would not tolerate any major surgery.
Yes. So, definitely we are ruling out first surgery of the sigmoid colon because of the bad liver.
Yes.
So, the other options remaining the sequential, or whether you do transplant followed by the surgery of the colon. If you do the simultaneous transplant and colon resection, the possibility of delayed healing or leakage and sepsis with the contamination of the peritoneum will be higher in terms of colonic resection. So if we have decided to go for the transplant, will be transplant followed by colonic, the third one.
Yes, that's exactly what we did, because simultaneous transplant and colonic resection would risk of leakage and infections in the post-op. So we plan to do transplant followed by colonic resection. Dr. Naveen, would your decision differ if your patient does not have a family donor? Yes.
So if we don't have a family donor,
Yes.
then obviously the DDLT is the only option then. But
Would you offer a DDLT organ for a patient with a coexisting liver?
that's a difficult choice, to be honest. I know if we would push for LDLT. If there is no LDLT, then I think getting a DDLT will be very difficult for this patient.
So, Dr. Naeem, is there a role for recipient first and then do a diagnostic laparoscopy before taking the donor if you are planning an LDLT operation?
Not for colonic tumors. I would directly do a laparotomy and do a staging lab after doing a laparotomy.
Yes,
not a diagnostic lab.
Yes, sir. Dr. Sainath, is there a role for mutation testing? Mutation testing, is there a role?
No. I think it's a localized disease.
Yes.
Localized colon cancer. It's always the surgeon first.
So the surgery.
And whatever molecular testing which we do is only to optimize which patient would benefit from an adjuvant or not.
Yes, sir. Thank you. So what we did is, in the first stage, we did ABO incompatible living donor liver transplantation, A220. There was no desensitization. Left lobe graft, GRWR of 0.92. She had a longer hospital stay because of the subacute liver failure. 3 months she stayed in the hospital. So we did second stage, 6 months after the transplantation, lap sigmoidectomy. Now she is 22 months post-op. She is in follow-up with no recurrence. Summary is that coexisting malignancy need not be an absolute contraindication for transplant. Complete detailed assessment for tumor and potential for cure is necessary. Sequence of treatment depends on urgency and tumor characteristics. Thank you.
Thank you, Prasanna sir, and I thank the panelists. Any comments, please?
Any comments from the audience, please?
I think everybody is waiting for lunch.
Any immunosuppression you change, sir, for these patients post-op?
No, we gave the standard immunosuppression.
Standard immunosuppression.
Yes, sir.
If it's a right colonic lesion, would you still want to do it stage-wise?
No, we would have done a simultaneous resection.
You would have done a
Also, it depends on the intraop hemodynamics.
Yeah.
Yes.
It was a sigmoid lesion requiring anti-resection, so you did.
Yes, sir.
No, it was a difficult decision actually. Everything about this patient was very difficult. She was managed outside for nearly a month and a half. She came very sick, and then we suddenly find this tumor. We did actually think of not doing the transplant, but then colorectal cancers, they do have a very good outcome, like Dr. Sainath said. And we felt if you say 50-year, 5-year survival is your benchmark for transplantation, then why shouldn't we consider transplantation in somebody who's got an 80% 5-year survival with colorectal cancer? And that's the reason why we went ahead and did the transplant. And we actually wanted to see if we can do one stage or maybe immediately after transplant. But she was so sick, there was no way we could have. She was in the ICU for almost a month actually after transplant because she was so sick. So we had to delay until 6 months for the resection.
Yes.
I mean, ideally, we would like to do that, within a month of transplant, just to reduce the risk of spread. But that was how the patient. That was the time the patient took to recover.
Sir, simultaneous sigmoid resection and colostomy is also an option, no, sir? I mean, without doing an anastomosis.
Yes, it is an option. Initially, we thought of doing that, but the intraop patient was on inotrope, so we decided we'll do it later. Thank you.
Right, thank you, Professor.